I'd like to just start by thanking Simon O'Connor. Simon has been a great supporter of our prostate cancer work, and I know when I have to front up to the Health Select Committee a little earlier this year, Simon was very much in support of allowing us to extend our program and the funding that went through this. So we do have some positives, okay. When we're looking at the standards of care for prostate cancer, very much at the moment it hinges around a single blood test called the PSA test. And when we are looking at changing that standard to improve men's lot in life, a lot of it is going to be looking at how we are going to do this. Now, what I'm going to take you through this morning is a method in which we can improve that standard with some technology. It is available at the moment, and maybe, just maybe, it could be a game changer for us. It's very important when we are dealing with prostate cancer, of course, not to forget the history. And so one of the things we're going to be looking at just for the next few moments is how we have actually got to where we are. And when we are looking at prostate cancer, it wasn't so long ago that the method of diagnosing this was with a digital rectal exam. The prostate felt hard and craggy, and inevitably the treatment that was used was going to be some form of hormone treatment, usually with a drug called stilbestrol that was highly toxic, and with the advent of good quality external beam radiation therapy, that's how the cancers were treated. And in the late 1980s, prostate biopsy really hadn't been discovered, and some of the work my friend and colleague Brett Delahunt and I did way back in that time was to play with what we called a true cut biopsy needle. This was a needle used for sampling breasts and other subcutaneous masses, and we decided to stick it into the prostate gland and start taking samples. And what was the great revelation to us was that we could actually have a look at the histology, the degree of aggression of the cancers actually before the treatment actually started. So we have come an awful long way from where we were with the rectal exam. And of course, this became the game changer. And this is prostate-specific antigen. It's a very small molecule. It acts as a thinning agent for the semen. And the reason we measure the amount of this molecule in the blood is that it has served as a very useful biomarker, and right up to the present time remains the frontline screening method for prostate cancer. This was discovered way back in the 1970s, and it was used initially just to monitor the progress of the disease, and it's only in recent times that it's really become part of that first-line screening program. And at the moment, PSA remains the basis of our current standard of care, and that is our problem. That is why we have the controversy. That is why we're not getting men tested. And the reason is that this is not the perfect blood test. Many of you will be well aware of this, that the things that can affect PSA are not just prostate cancer, but great big prostates make lots of PSA. If a man has an infection which may be otherwise clinically impossible to diagnose, it'll stick the PSA level up. Old men have higher PSAs. And in addition, high PSAs may not actually reflect the true burden of the cancer. And in fact, as Brett will tell us maybe, some of the most highly aggressive prostate cancers we deal with don't generate much PSA, so the blood test becomes ineffective. Nevertheless, what we have learnt is that when PSA measurement started, the overall prostate cancer mortality dropped considerably by about 40%, and that is an incontrovertible truth. So we do know that screening to some extent is a very useful and beneficial thing that can be done using PSA as the basis for what we're all up to. The problem with the PSA, with all of its quirks and the misunderstanding of it, and indeed the misuse of it, means that as urologists, we've learnt over the years to make a whole lot of refinements to this blood test. We've learnt that we have to be patient with the measurement, so we never act on a single abnormality. The test is always repeated. We know that that must be combined with a rectal exam so that we can get additional clinical information. That's what makes the test more powerful. We also need to take into account the importance of prostate size. And if we do have a prostate abnormality in terms of the PSA, it makes common sense that this is the sort of biomarker that we can watch over time. And so if we have a man that's got an elevated PSA, but it just does not change over a 3 or 4 year period, it provides quite a lot of reassurance that we're probably not dealing with any form of malignant process. Nevertheless, if the PSA starts going up very quickly, it can actually then tell us that maybe we've got much more of a clinical problem. And the other big one that we've had trouble with is these reference ranges. So what that means is that for a man of the age of 60, what is the expected normal value of PSA for him? The honest answer, we actually don't know. If you're in North America, your PSA level of about 2.5 may be regarded as the upper limit of normal. It's not the same in New Zealand. We're looking at 4 to 4.5. This international disparity is one of the reasons why in North America PSA testing has been much, much more controversial than in fact it has in New Zealand. It's the reference ranges. They're not built on a hang of a lot of science. They tend to be very arbitrary, but it also weakens the argument about testing. If we do have an abnormal PSA or a man's got an abnormality on rectal exam, we then fall back on needing to biopsy the prostate. And if we're looking at the second piece of armament that we have, PSA being number 1 and the trust biopsy number 2, this is also far from perfect as a diagnostic exam, and there are several very, very good reasons for this. The first and foremost is that grayscale ultrasound, which is what we all use as urologists, is effectively useless at seeing any form of prostate cancer. Prostate cancer usually cannot be seen on ultrasound. Similarly, you can do a CT scan of the prostate itself. You probably won't see the cancer. You may see if it extends outside through the gland, but it's not particularly effective. What that means then is if you're using ultrasound guidance to do your prostate biopsies, nearly 2/3 of the biopsies and the ultrasound helping it won't provide any useful data at all. And in fact, the cynics, and they are probably correct, would believe that most of the clinically significant cancers on conventional trust biopsies are usually found by chance. In addition, some of the cancers that are found, and what I'm referring to here are the very low-grade, more indolent cancers, are often inappropriately sampled. And this is where we get into the trouble of the low-grade, non-aggressive cancer that will probably never have any effect on a man's lifespan getting treated. This is the reason why we have been under criticism. And throw into that the risk of complications from prostate biopsy, and really we've developed a little bit of a hornet's nest. Having said that, and once again getting back to our original data about how PSA screening has helped, we must not forget that the early detection and the treatment of these high-grade and aggressive cancers is absolutely critical to achieving the best prostate outcomes. So we do need to keep on the quest for early diagnosis. Unfortunately, when it came to the United States Preventive Services Task Force, they grabbed hold of all of these issues to do with PSA testing. They grabbed hold of the inaccuracy of trust biopsies, and basically the Services Task Force came out and said, look, there's a whole lot of incomplete information. The PSA tests and the biopsy are leading to inappropriate treatment recommendations. Therefore, there will, in North America, be absolutely no support for prostate cancer screening. And that was the big 2012 decision that they have made that had a huge global influence. Now, of course, this was picked up by the government, and there was a health select committee that was sent to look at this, and the findings from that agreed with the United States decision that there would be no national screening programs implemented, but that the question of prostate cancer testing would be looked at by a prostate cancer task force. And that task force ran for a year. There were a whole lot of recommendations come out of it, one of which was the establishment of the Awareness and Quality Program, and you've heard a bit about that from Mark von Dadelson this morning, how we've been running for several years, but for a number of reasons, which I will not repeat, we have met a degree of slowdown that has been unfortunate. And it's unfortunate because initially we actually had some pretty good pamphlets coming out. This was one of them. And this was all about prostate cancer, and I've managed to clutch this Prostate Cancer Foundation brochure that you've got here, and it's got a whole lot of really good stuff in it. And it is a little disappointing that an organisation like the New Zealand Cancer Foundation can come and do this with comparatively smaller funding, and yet nationally we are struggling to get the message out there. And that message really is very simple, and where we've come to pretty much has been a stalemate. This is a magnetic resonance scan. And I'm going to tell you a little bit about MRI because this is really important, okay? MRI consists of a very, very powerful electromagnet here. If you've ever heard an MRI, and I know that with those of you who have had recent prostate cancer diagnoses, you will know exactly what I'm talking about. This is a very loud machine. The room shakes, you've got to have earmuffs on, but what it does is provide a lot of information. And the way magnetic resonance scan works is that it's all about water. And what this very, very high-powered electromagnet in the scanner does is that it rotates, it orientates all the water molecules in our body. And it's a microsecond process. And as these molecules rotate or they spin, and as they return back to their normal state, they emit radiofrequency waves. And these radiofrequency waves are picked up by detectors on the center of the scanner. And what happens is that there are various parameters that can be looked at when these water molecules spin and they rotate back again. And there are actually 3 of them. And these are all to do with the manner in which the radio waves are looked at. So you'll see on the board there, we've got this thing called a T2. This is to do with the time it takes for the molecules to spin back. And these weighted images are really, really good for having a look at the anatomy of the prostate. The other thing that we know about cancer is that because it's very dense, water diffuses through it a lot more slowly than normal tissues. So if we have a look at the diffusion of water through the prostate, it is a very, very good method of learning about the presence of a cancer and also the function of it. If the water goes through it less slowly, it's going to look very dark on an image. And interestingly, these MRI images correlate very, very well with the Gleason scores that Brett Delahunt down here and his team have worked on internationally for many, many years. And also the third thing we can do with MRI is that we can inject me in with a tracer, and this tracer called gadolinium is picked up by the bloodstream, and this is very effective at picking up really, really tiny prostate cancers. Throw the whole 3 together, we've got what we call a multi-parametric MRI, and suddenly it becomes pretty useful at determining the likelihood of a clinically significant prostate cancer. And that is the key phrase. If the magnetic resonance scan is normal, it doesn't necessarily rule out a cancer, but if it does miss a cancer, it's likely to be of no clinical significance. And what we've got here is this scoring system. Now this PIRADS means Prostate Imaging Reporting and Data Systems, okay? For the low scores down here, men are very unlikely to have prostate cancer. As the score goes up, and this is how things are reported to me as a urologist, the likelihood of prostate cancer goes up, and the higher the score, the more likely that is also to have a high Gleason score. It's going to be more aggressive. And so we can look at these numbers and we can say, okay, if we do this MRI scan and we've got these high scores, these are the men that we can be confident should be recommended for a prostate biopsy. And if you're wondering what an MRI looks like, this is it. And I'm just going to give you a little bit of an anatomy lesson and get you orientated here, okay? So this is a cross-section down through here, through a man's pelvis. And over here we can see the right hip joint, the ball and socket joint, left side over here. This white thing is the bladder. The reason it's white is that it's full of water, and that's how MRI shows up water. Down here is the rectum, and this thing is the prostate gland. It's in two bits. There's what we call a central zone to it, and there is a peripheral zone as well. And down here is the prostate cancer, just sitting right here. And that is a very effective thing to see, and the reason it's useful is that if we then marry up an MRI here with an ultrasound, we can use ultrasound guidance to absolutely pinpoint the area of the cancer. Here's the cancer on the MRI. Here is the region that we need to stick the needle into. So all of a sudden, we can get very accurate diagnoses. The needle that we put in goes up through what we call the perineum. This is how we get very accurate biopsying, and this is a technique that we use called transperineal prostate biopsies. This young registrar here doing the transperineal biopsies to get that very accurately. So in the end, what does this mean to us? Well, Dr. Lefebvre of the United States Preventive Services Task Force, he caused us a lot of grief by stopping national screening. But he was correct in one respect, and that was that he labelled prostate cancer a particularly serious health problem. And then we had the European group with their studies, and they showed that by screening there was absolutely no doubt that we could decrease prostate cancer mortality by about 20%. And I guess the issue that we have is that men who don't undertake the screening, these are the ones, of course, that often present with the late stage and the often incurable prostate cancer. And I guess once again, we come down to the equation is that in terms of the harms of screening and why they should be taken seriously, there's no question that they should not outweigh the potential to save lives. And really, at the end of the day, men certainly deserve a more effective screening program that really does reduce the harm and still saves the lives at the same time. History is really, really important. And I think, as we've had alluded to already this morning, I guess a lot of men fear the screening more than the cancer itself, and that really is a tragedy because it should be nothing like that at all. Also, we need to realise that the prostate cancer, it really does globally kill many, many more men than any other cancer globally, apart from lung cancer. And so where we're coming down to is that men deserve a screening model that can much better identify those that would benefit from biopsy, and in addition to biopsy, the cancers that matter. If we can do that, we're going to avoid a lot of the controversy. So maybe, and just maybe, we could be looking at a new standard of care. We need to get away from our reliance on PSA. It is not going to work. The public health physicians who have been taunting us for years and years and years get at prostate cancer screening because of the weakness of this test. We need to do something better. So maybe if we can incorporate it with multiparametric MRI, we are going to get a game changer. We're going to get a method of prostate cancer detection that is more robust. It will definitely lead to a reduction in the number of biopsies, and fewer biopsies and fewer samples means fewer complications. That's been a big criticism of prostate cancer diagnosis. In addition, if we're getting improved diagnostic accuracy, then almost certainly that's going to apply to the intermediate grade and the high-risk cancers that we are so interested in picking up. And on the other side of the coin, it means that those low-risk indolent cancers we can leave alone. And of course, with active surveillance being one of the mainstays of our treatment, the more men that we can direct to that, rather than some of the other curative treatments such as external beam radiation therapy and radical prostatectomy that inherently have a whole lot of side effects, then we must be doing men a whole lot of good, and surely it will help silence the critics. At the end of the day, it's going to come down to this. And I don't know whether you've ever seen $1 million bill, but if you've got 3 of them, you're going to be able to afford the latest 3T generation MRI scanner. They are expensive pieces of kit. And before I came up here, I gave Lance Lawler a call. He used to be one of my house surgeons, but he was smart enough to get into diagnostic radiology and is now the managing director of Pacific Radiology. And I said to him, how much are these scanners? And he said, well, you can pick up an ordinary one for about $1.5 million. You want the best, which is what they've got installed for us in Wellington, a new 3T scanner. It's about $3 million. Running costs, 10% of the capital cost, so it's going to cost about $300,000 a year. Is it worth it? Interesting one to ask the politicians, I think. Simon, I'm glad you managed to escape in the nick of time, but we can get you later. But look, this is the sort of investment we need to make. And a lot of it is transference of cost. If we're doing MRIs, we don't need to do CT scans. CT scan is a waste of time in terms of staging men for intermediate or even high-grade prostate cancer. There's other things we can do. We need to be smart. We've got the technology. We've got to have the confidence to implement it. We are going to need to have an awful lot of political support. But maybe, just maybe, we can make some progress. Thank you very much.